So moving into other clinical populations and discussing their exercise recommendations, we're going to go ahead with diabetes mellitus. And a little background about diabetes. Uh, it's basically diagnosed by high fasting glucose levels. And there's a few different ways that can happen, but overall characterized by insufficient insulin or an inability to use it properly, or what we would know as insulin resistance. So it affects a lot of people in the United States. It's projected that it will continue to rise over the upcoming years. And diabetes, especially type 2 diabetes, is one of those conditions that can be prevented and treated with lifestyle changes. So, diagnostic criteria for diabetes, you can see normal, prediabetes, diabetes. Fasting blood glucose, the magic number is 126. So 126 or above is diagnosed with diabetes. Glycosylated hemoglobin, or HbA1c, greater or equal to 6.5. This is a better indicator of long-term glucose regulation. Then we have the 2-hour glucose tolerance test here. But ideally, these are the big numbers that you would want to remember. So fasting blood glucose 126 or above, or glycosylated hemoglobin 6.5 or above. And you can see the pre-diabetes range here. So remember, 5.7 was the cutoff for a risk factor. But to be diagnosed with diabetes itself, 126 is or 6.5 is the number. So different types. So type 1 diabetes, which accounts for a very small percentage of individuals with diabetes. It's an autoimmune disease where the body's own immune system destroys the beta cells in the pancreas. The beta cells of the pancreas are the ones that produce insulin. So we need insulin in normal situations to decrease blood glucose when it's elevated. So if we don't have beta cells, we don't get the insulin. If there's insufficient insulin, so glucose is going to be high. The way type 1 is treated is insulin. It's the number one treatment for type 1 diabetes, and this can be either injections or an infusion pump. Type 2 diabetes is characterized by insulin resistance. This is by far most of the cases of diabetes. This is more of a lifestyle condition in most cases, associated with obesity, dyslipidemia, sedentary lifestyle. And if you get a lot of those things together, you can actually get what is called metabolic syndrome, which we'll talk about as well. But for type 2 diabetes, insulin resistance is the big part of it. So exercise is especially beneficial for people with diabetes and also preventing diabetes, because when muscles contract, they have what's known as an insulin-like effect. So the way most cells get insulin or get glucose into themselves is insulin is released. It's a hormone, binds insulin receptors. That's going to cause these glucose transporters to move to the surface of the cell membrane, and that allows glucose to come in. So in type 2 diabetes, this process isn't working. So even though there's insulin, the transporters aren't moving. So good thing is, though, about exercise causes the same effect. So even if you're insulin resistant to some degree, muscle contraction itself helps facilitate the uptake of glucose in the cells, which explains why exercise is so beneficial for diabetes. So here are the recommendations for diabetes. There's a lot of things to think about when prescribing exercise for diabetics, but in general, these are the guidelines. So overall, some of the big differences you're going to see here: more frequent exercise. Again, that's that insulin-like effect of skeletal muscle. Ideally, no more than 2 days without exercising. Just an every day would be fine in diabetics, just due to that repetitive muscle contraction. Intensity-wise, usually moderate is a good place to start, but there's really nothing that precludes diabetics from moving into the vigorous range and working at a higher intensity to help with the caloric expenditure. So as far as duration, you can see it's on the upper end, so 150 to 300. So with diabetes, generally one of the key things you want to always remember is caloric expenditure is important. So the more calories you expend, usually the better the result. type vary, similar to what we've seen before. Resistance training, highly recommended in diabetics. Again, that skeletal muscle effect that you get with muscle contraction. So it is highly recommended that diabetics engage in resistance training as well. Flexibility, no big secrets here, kind of the same as we saw for healthy adults. So some of the things to think about with diabetes, some acute complications that can occur. So either high blood glucose or low blood glucose can be a problem. So hyperglycemia is when blood glucose is too high. And that can have a lot of negative effects: dehydration, headache, weakness, fatigue. You can actually get ketoacidosis. So when carbohydrates can't be used by the cell, the liver is going to form ketones. So the body can use that. The brain can use it as well. But sometimes that results in a drop in pH. So you can get a condition known as ketoacidosis, which could be very severe. So some numbers you want to think about: before exercise, blood glucose should be in a normal range. So according to the guidelines, 90 to 250, and that's just a pre-exercise glucose, not necessarily fasting. If blood glucose is 250 or above, and there's also elevated ketones, you should not exercise. And then whether or not ketones are there or not, if it's 350 or above, the diabetic should not exercise. Hypoglycemia is when there's too low, and that's defined as less than 70 milligrams per deciliter. This is also a contraindication to exercise if it's too low. This can be caused by a multitude of factors, like too much insulin. If someone was taking insulin injections and injected too much, that could drop blood glucose. Not eating enough carbohydrates, poor planned exercise, meaning not timing it around insulin intake or carbohydrate intake as well. So some of the symptoms, the same things you get if you're haven't eaten all day and you feel lightheaded. So shakiness, weakness, nervousness, dizziness. But you can alleviate a lot of the things that go on with hypoglycemia by just altering several things, like changing the insulin timing before or after exercise, reducing the dose if necessary before exercise, or just eating more carbohydrates. And then time of day, generally for diabetics, it's recommended that they exercise in the morning, and that's to potentially prevent someone becoming hypoglycemic later in the evening when they might be sleeping. So some other things about the exercise prescription: again, maximize caloric expenditure, reduce hypoglycemia as we discussed. Even having an exercise partner is good in case there is hypoglycemia that occurs. Resistance training is very good as for diabetics, and also gives a lot of benefits similar to aerobic exercise with the in the context of glucose regulation. Some diabetics have a condition called retinopathy, which is damage to the blood vessels in the eyes. And so a lot of that's dependent on pressure. So if someone has retinopathy, it's generally recommended that they don't engage in high intensity exercise or resistance training, just because that increase in pressure could damage the eyes. Neuropathy also, so damage to the nervous system that can alter the cardiovascular response when you think about heart rate, and etc. And then peripheral neuropathy is common in type 2 diabetics, where they oftentimes leads to blisters or what are called diabetic foot ulcers. So foot care is really important in type 2 diabetics. So a few other things. If not contraindicated, higher intensity is good. So vigorous intensity should be encouraged, just to get that muscle contraction effect, and also caloric expenditure. High intensity interval training may be okay if they can handle it. As I mentioned earlier, no more than 2 consecutive days without aerobic exercise due to that repetitive effect of muscle contraction. And then when doing both aerobic and resistance training is recommended to be done first, and that has been shown to lower the risk of hypoglycemia. All right, so that's diabetes. Metabolic syndrome is similar, but it's more of a cluster of different things. So, metabolic syndrome diagnosed by the presence of a group of risk factors, and you can see those listed here. Uh, about 35% of the U.S. population meets these criteria, and generally, as you get older, uh, it becomes more common. Also, it's very common in individuals who are overweight and obese. So here's the criteria, and there are three major organizations that each give their own criteria. So I'm just going to kind of talk about these in general, but there are, in most cases, there's five different things, and if you have three of the five, you can be classified as having metabolic syndrome. So first one's going to be waist circumference. So you can see the numbers here. This is more of a waist hip ratio that this organization uses, but waist circumference, different males and females, that you've seen these numbers before. Each organization has different cutoff, but the big thing is waist circumference is one of the risk factors. Insulin resistance or glucose regulation. So fasting blood glucose 100 or higher. HDLs by themselves. So in males and females, you see those numbers 40 and 50, like we saw for risk factors. So that's the criteria. And again, not all of the organizations use the same numbers, but the important thing is low HDL is one of the components of metabolic syndrome. Triglycerides as well, another lipid, so higher than 150 milligrams per deciliter. Then blood pressure as well, elevated blood pressure. So you can see that there's different criteria used across the board, but bottom line is on the lower end, 130 over 85. That's the cutoff for elevated blood pressure as in regards to metabolic syndrome. So if you have three of those five, or you're positive for three of those five components, then you're diagnosed with metabolic syndrome. So as far as treating it, so there's a lot of underlying risk factors. So if obesity is the primary thing, that should be targeted. If it's high blood pressure that should be targeted. Blood lipids are the problem, that should be targeted. This can be done via physical activity, dietary changes, so decreased calories, sodium, increased fiber, low-fat foods, etc. And then also medications can be used here. So specific conditions should guide the exercise prescription. So there's five possible things, right? So if one of those things seems to be one of the major problems, that's kind of where you should target. So other than that, the recommendations are going to be similar to what we saw for diabetics. So 150 minutes per week, moderate intensity is a good starting point. Weight reduction is important, so increasing that caloric expenditure, if possible, is recommended. Daily exercise is recommended, similar to as we saw for diabetics, and this can be accomplished in short bouts of activity throughout the day. And then, again, the duration may need to be longer because caloric expenditure is really key here. And then resistance training is also applicable here if it's not contraindicated. So again, reduction in body weight really important to up the caloric expenditure, up to duration if necessary. Combine resistance and aerobic training as well, like we said. And then as far as just muscle strengthening activity, general recommendation, at least 2 days a week, but there's nothing wrong with doing it a little bit more frequent than that along with aerobic exercise. All right, so moving into just cardiovascular risk factors. So I wanted to go through a few of these. And sometimes individuals only have certain risk factors, not anything else, and we need to kind of think about how to guide that exercise prescription. So those with dyslipidemia, these are the normal ranges that there are for the different blood lipids. So you can see LDL, HDL, triglycerides, and what's considered normal, what's considered high or very high. So like LDL, so remember, but 130 is a cutoff for a risk factor, and that's kind of where you start seeing the borderline high. HDL, it's pretty straightforward, 40, 50 males, females. Anything lower than that is considered low. And then triglyceride, there's different ranges. Generally speaking, once it gets over 200, it's considered high. So a little bit about cholesterol. So it's a fat, really important in the body actually. Important part of hormones, also important part of the cell membrane of different cells of the body. So it's important, but too much of it can lead to problems. So a lot of cardiovascular problems. So the cholesterol is carried in the blood by lipoproteins. And so there's different types of lipoproteins, and this is where the LDLs and HDLs come in. So there are more than that, but again, there's the ones that are most focused on in the context of exercise are LDLs and HDLs. So big thing about LDLs and HDLs, so LDLs tend to transport cholesterol from the liver to cells of the body. So that leads to a lot of times cholesterol and lipids being kind of in the vasculature and leading to blockage in blood vessels. And then HDLs kind of do the opposite. They transport cholesterol from body tissues to the liver to get rid of, and that's why we think HDLs are so good, because they kind of remove cholesterol from the blood and move them towards the liver. So a little bit about LDLs, HDLs. So again, these are lipoproteins that carry cholesterol. So LDLs have what's called an apolipoprotein on the surface, and you see that here in this picture. It has one called apolipoprotein B, and that tends to promote the plaque buildup in the vessels, as I was mentioning earlier. Then HDLs have a different apolipoprotein on the surface. They have apolipoprotein A, and that promotes the removal of cholesterol from the plaques in the bloodstream. So, key point: these are just the LDL and HDL are just cholesterol carriers, and they tend to do different things as the direction of cholesterol deposition, either bringing it out to the tissues, potentially causing problems, or bringing it to the liver to get rid of it. As far as treatment for dyslipidemia, exercise is really good. Some of the most common medications that someone with dyslipidemia is going to be on is called a statin. And those are really good at lowering cholesterol levels, lowering LDL levels. But in return, there's some negative effects of them. Some dietary suggestions: reduction in saturated fat, increase in monounsaturated fat, omega-3 fatty acids in the diet or as a supplement have been shown to reduce triglycerides, and then increasing fiber as well. So here's the recommendations, and you can see they're not overly different. Intensity for aerobic starting on the lower end, increasing frequency of multiple days a week, time very similar to what we've seen before. Again, this is one of those things like the more tends to be better. Resistance training very similar to what we've seen in other populations, even healthy flexibility, it's very similar as well. So a couple of important things: statins are the drug that's most commonly taken in those with diabetes, and this drug actually can cause muscle damage. So a lot of times when people are taking statins, there's a lot of muscle weakness or muscle soreness that's occurring. And then it takes a while to see changes in lipid profiles, so due to lifestyle changes. So it's one of those things you just got to commit to it and give it a month, 2 months, 3 months, whatever it takes, and then you'll probably start seeing some changes. So moving on to hypertension. So hypertension is just high blood pressure. Using the new criteria that came out in 2017, about 47% of U.S. adults have hypertension. And there's two types of hypertension, are primary and secondary. So traditionally primary, what's also known as essential hypertension, is the most common, and even though we can speculate on the cause, we don't know a direct cause for sure, and that's kind of what makes it primary. But some of the speculated things: genetics play a role, obviously, diet, physical inactivity, but the bottom line is you don't know for sure exactly what's causing the hypertension. Whereas secondary hypertension, you do know the cause. So it's due directly or secondary to another condition like kidney disease or hormone secretion or any other condition, but you can identify the cause of the hypertension. So hypertension is commonly treated with medications. It's once your blood pressure gets to a certain like level, like in the hypertensive zones, usually they will recommend medications for it. But exercise and dietary changes are also really important for this. So lifestyle changes, increasing physical activity, and also altering the diet is good for hypertension. As far as weight loss is important, reduce smoking if they're smokers. As far as dietary changes, reducing sodium intake, reducing alcohol consumption, there's a whole diet that's called the DASH diet, which stands for Dietary Approaches to Stop Hypertension. And it is generally recommended that individuals with hypertension follow that diet. It'd be really similar to what we just said: low sodium, reducing alcohol, increasing fiber, etc. All right, and here's the standard ranges for blood pressure. So hypertension 130 over 80 is the cutoff now for hypertension. You can see there's different stages of hypertension. So treatments, again, drugs are really utilized here. And as far as lifestyle changes, exercise, dietary changes like we mentioned, and weight reduction, really important. So as far as exercise training, lowering blood pressure, it has been shown pretty much consistently that exercise training can reduce blood pressure. It reduces it more in those who have high blood pressure. So in hypertensives, it can reduce it by 5 to 8 millimeters mercury. If it's just elevated, like it's close to that 130 over 80, expect a 2 to 4 millimeter mercury drop. And then even in normotensives, you can expect a slight drop due to exercise training. So here are the guidelines for hypertensives. And you can see it's, again, similar to what we've seen for healthy adults. Classically, for hypertensives, it was recommended to stay in the moderate intensity zone, but it was thought that moderate intensity exercise was better at lowering blood pressure than higher intensity. But that hasn't been consistently shown, so there's really nothing wrong if a person wants to engage in vigorous activity to go ahead and do it. Time, again, is pretty standard there. Resistance training, generally recommended unless it's contraindicated on some level. So if blood pressure is too high, then it wouldn't make sense to engage in intense resistance training. Flexibility, very similar to what we've seen in other populations. So things to consider with exercise training: might get an exaggerated blood pressure response, and you can look at some of the numbers here. So if systolic gets over 220, diastolic over 105, you want to make sure it doesn't get that high. So you either stop exercise or reduce the intensity. Like I mentioned earlier, vigorous intensity is not necessarily contraindicated, and it's fine for hypertensives to engage in vigorous or higher intensity resistant or aerobic training. But again, moderate intensity is probably appropriate for most individuals with hypertension, just to get them to adhere to the program more potentially. And again, just getting the benefits of exercise without and making it more applicable to more individuals. Weight reduction is important again, and then Valsalva maneuver should be avoided, and that's so that breath holding especially when you're engaging in resistance training, that can elevate blood pressure too much. So drugs, so beta blockers, diuretics can affect the exercise response. So for instance, beta blockers are going to lower the heart rate, so the heart rate's going to be lower. That technically could reduce aerobic capacity, And so you consider that. And so again, you wouldn't want to necessarily use the classic way of prescribing exercise with heart rate on somebody somebody taking a beta blocker, unless you had an exercise test data to kind of see where their heart rate's going to be while they're taking the beta blocker. Diuretics and beta blockers can affect the thermoregulatory processes in the body. So that's something to consider as well. So temperature regulation, indoor versus outdoor activity. Then a couple other things to think about. Peak exercise heart rate during an exercise test is the way to go. If instead of, I should say, instead of using an equation to predict max heart rate, RPE is a good safe bet to use. If if you don't have a good peak heart rate to go off of due to medications, RPE is always a safe bet. So you can always use RPE to prescribe intensity. Older individuals, obviously, as you get older, there's the incidence of blood pressure or hypertension is going to go up even more, and so it's when you're going to be dealing with a lot of older adults when in the context of hypertension, and so following guidelines not only for hypertension but also for older adults is important here, and we'll go through older adults as well. Post-exercise hypotension. So even in healthy adults who are normotensive, after a bout of aerobic exercise, there's a period where blood pressure will drop. It's called post-exercise hypotension. It's actually a good thing, but it's just something to be aware of. And in those with hypertension, it seems to be exaggerated. So you just want to make adjustments for this. You know this, just make sure the person doesn't become hypotensive after exercise so much that they might experience symptoms like lightheadedness or anything similar. So things to think about: active cool down, and while they're recovering from exercise, just to prevent that drop in blood pressure from being problematic.